rapid access to comprehensive oncology data, and survival analysis. This is the Enko Toolkit.
Okay, you know the drill. You've got hours of dense clinical guidelines to review, but in reality, you have maybe 10, 15 minutes with your patient. And in that time, you have to make one of the highest stakes decisions in early-stage breast cancer: adjuvant chemotherapy. Yes or no?
Right? It's this gap, this immense pressure between this mountain of evidence and the ticking clock in the exam room. That's where the friction is. It's precisely where we need to be at our best, but it's also where it's easiest to miss a nuance.
And that's exactly what this is for. This is the solution: instant, streamlined, and absolutely rigorous evidence-based interpretation of the Oncotype DX score. It puts the guidelines right where you need them, when you need them.
So how does it all work? Well, before we even touch the app, we have to deconstruct the score it's built on. Because this isn't about blindly trusting a calculator, it's about deeply understanding the evidence so you can trust the automation. Let's dive in.
So at the very heart of this is the Oncotype DX Recurrence Score, or RS. Now this isn't just some arbitrary number. It's a sophisticated 21-gene assay that looks right at the tumor tissue. It's measuring 16 cancer genes against 5 reference genes. The output is a score from 0 to 100 for our ER-positive, HI2-negative early breast cancer patients. And look, it's doing 2 critical jobs at once. First, it predicts the risk of distant recurrence, but maybe even more importantly, it helps us quantify the absolute benefit of adding chemotherapy to standard endocrine therapy.
So let's break this down by patient group. First up are node-negative patients. The foundational evidence, the bedrock for this group, comes from the landmark Taylor X trial.
And this table right here shows just how critical the nuance is. For patients over 50, it's pretty straightforward. A score from 0 to 25 means no benefit from chemo. Simple. But for our younger patients, age 15 or less, it's a different story. A score of 0 to 15, still no benefit. But in that intermediate range, 16 to 25, Taylor X found a modest but definitely significant benefit. We're talking about a 6 to 9% absolute benefit in that 21 to 25 range. Then, for any patient, any age, with a score of 26 or higher, the benefit of chemotherapy is absolutely clear.
Okay, so that's node negative. Now let's move to our node positive cohort, specifically those with 1 to 3 positive nodes. Our guide for this group is the practice-changing RXPonder trial.
In this slide, this highlights a really crucial pivot in our clinical thinking. For these node-positive patients with a recurrence score of 0 to 25, the key determinant is no longer age, it's menopausal status. For postmenopausal women, there is no benefit from adding chemo. Endocrine therapy alone is non-inferior. But for premenopausal women in that exact same score range, there is a clear, undeniable benefit from chemotherapy. And just like in Taylor X, once that score hits 26 or higher, everyone benefits regardless of menopausal status. This is the source code. This is the bedrock of the entire tool. It's not some proprietary algorithm's opinion. No, it's a direct, digital translation of the findings from these 2 monumental New England Journal of Medicine publications, Sperano et al. For Taylor X and Kalinsky et al. For RXPonder. All right, so we've just walked through that complex, multi-layered clinical decision tree. Now let's see how Oncotoolkit takes all of that and automates it in literally a matter of seconds.
Take a look at the interface here on this slide. It is intentionally, almost radically simple. You just enter 3 key data points: the patient's recurrence score, their nodal status, and their age or menopausal status. That's it. That is all the tool needs to do the work. You hit calculate, and the result is instantaneous. It gives you the genomic risk category, sure, but more importantly, it provides a crystal clear treatment recommendation that directly cites the evidence. So for this example here, a postmenopausal node-positive patient with a score of 24, it correctly references RXPonder and tells you no chemotherapy benefit. Endocrine therapy alone is non-inferior.
Okay, and this is always the most important question for any clinical calculator, right? In this high-stakes environment, trust isn't just given. It has to be earned through absolute transparency.
And here is the answer. Every single calculation comes with this logic trace. We don't believe in black boxes. The math and the reference tables are right here for your review. It shows you the exact clinical context it identified, the primary source evidence it pulled from, and the specific logical path it followed to generate that recommendation. It's all right there.
But the tool's power actually extends way beyond that individual patient encounter. It was really designed from the ground up to be the launchpad for your next research project.
See that Save button on the results screen? Every single time you run a calculation, you can save it with an optional de-identified patient ID. And what you're doing is building a local, structured, research-ready database of your clinical interpretations right on your device. You can see it in the Saved Results panel on the right.
And this enables a beautifully seamless research workflow. You save your interpretations as part of your normal clinical day. Then, with just one tap, you export the entire cohort to a clean CSV file. From there, you can polish that data and move straight into your statistical analysis, like generating Kaplan-Meier curves.
And the Oncotoolkit ecosystem is built to support this whole workflow. This slide here shows the CSV Data Polisher. It's a companion tool designed specifically to take that data you just exported and get it ready for analysis fast. It can handle missing values, it converts variables, it basically ensures your data quality is truly research grade.
So this completely reframes the tool, doesn't it? It transforms a routine clinical task into the very first data point of your next publication. Your next cohort study doesn't start with a grant application or a huge database request. It starts with a single, evidence-based calculation. The only question left is, what are you ready to discover?